Hi, good afternoon. This is the practical for osteopathic approach to the older patient, and Nick has agreed to be my patient for the day. So if you remember, the patient that I was talking about in my lecture was a 93-year-old woman with severe osteoporosis and history of compression fractures, peripheral arterial disease, and she could not lay flat on the table. So positioning your patient, especially your older patient, is really important in the hospital setting. You can move the bed up and down, but on a regular treatment table, you might use pillows or wedges. I'm going to use a couple things. I have a body support system. I'm not promoting that, I don't sell it, but this can conform to support the body pretty well. So I'm going to give you this. Oh, sorry. And then I also used a couple pillows. So if you wouldn't mind bringing your legs up and maybe sliding your butt. Yeah. Okay. And then, of course, for the legs, so you can use a bolster, a thick bolster. Yeah. So you can see he's got about a 30-degree incline. Are you comfortable?
Yeah.
Yep. So this is a comfortable position to treat your older patients who have a kyphotic curve, and you want to give them great support. So positioning the patient, optimizing fluid motion by treating the diaphragms, and gentle range of motion for the joints, and being very sensitive to the barriers of motion. So I'm going to actually start at the thoracic inlet. I'm going to bring my hands over the top with my fingers very lightly pressing underneath the clavicles. My thumbs are up and over the trapezius muscles. I've got Simpson's fascia in my hands, and I'm really easily motion testing, side bending, rotation. My kyphotic person may be tipped anteriorly. He is not. He does prefer a rotation towards the right side bending. So by asking you to take a few deep, full breaths, I'm going to follow the motion of the tissue and exaggerate that motion just a little bit, and I'm bringing tissue with me, imagining the intention of opening that fascia and opening the outlet. And then the very last one, I'm bringing them a little past midline, and I'm going to reassess. Generally start with this in the hospital setting as well. I might take my hands and bring them under pectoralis major and do just a little bit of a lift. He's got very compliant and springy tissue, but my person who is extremely kyphotic and has muscle wasting, sarcopenia, may not have this kind of motion, but I'm going to just enhance the space and with each breath, and expanding space. My thumbs are around lymphatic ducts as well. I might also do just a little light compression on lymphatic ducts. So the best we can do is to help to relieve our patients' discomfort and help them to be as mobile as possible. So some soft tissue for the cervical region. I'm working longitudinally right now. And my fingers are also going up into the suboccipital region. Certainly could treat the autonomics with a little decompression of the suboccipital region. My fingertips are following the curve of the occiput. And my thumbs are on the mastoid processes, and I'm aware of motion through the cranial base. He's tweeting out right now. We talked also about the occipitomastoid suture and doing a V spread. So bringing my, can't show you here, index finger and middle finger, one on the temporal bone and one on occiput, and doing a little bit of a distraction. And my other hand will come to the frontal region. I'm going to send a bit of a compressive wave through the fluid and spreading OM suture. My intention is to balance the autonomic nervous system, to free the vagus nerve. Treating suture. Yeah. And I'll treat the other side as well. Of course, you're working with the motion that's present. I have my index finger behind the ear on the temporal bone. My middle finger is on occiput. I'm suggesting a little distraction. And my opposite hand is sending a vector of force, very light through the fluids to that OM suture. And I'm going to recheck. So let's just get a sense of the motion. Back to the suboccipital region. Gently doing a little bit of spread. Lateralizing the paraspinal muscles through the cervical region, both sides. I'm sensing and treating simultaneously. And I'm back to the thoracic inlet. I want to introduce a little more motion in my patient's rib cage through the whole mechanism, through the thoracic region. And I'm going to go to the respiratory diaphragm now. Really important area to treat. So using my entire hand on both sides, just making contact with my thenar eminence on the lower ribs, cartilage, and do a little motion testing. Then his thoracolumbar region has a preference to rotate to the left. You see that? So I'm going to once again ask my person to take several big breaths in and out. I'm going to follow each exhalation in the position of ease. I'm going to his left. I'm not using my thumbs poking into the epigastrum or under the ribs, but I'm bringing all this tissue off. This is the third one. There we go. And I'm bringing him past midline. And and good. I feel good motion through these ribs. Remember that with a person who has a big kyphosis, there's shortening of the pectoralis muscles, a little internal rotation of the humerus, like tightening. Oftentimes the tissue may feel a little dry, leathery. So I'm going to bring this entire upper arm complex through a range of motion with one hand monitoring in the axilla, and I'm doing a little traction, watching his head move. He's got good fascial motion. This is about 30 degrees. I'm going to step out for about 45 degrees, little rocking, stretching, and 90 degrees. So I'm thinking traveling all the way up to the attachment of trapezius muscles across rhomboids. Yep. And then as much as his arm is able to move, I'm going to turn and support this arm with mine. And I have great access to his ribs, to a long stretch on the latissimus dorsi, all that fascia down, and I'm going to make some space between ribs, rocking, pressing, thinking of intercostal space moving with the woman that I saw in the clinic and I presented in my lecture had less range of motion, certainly, and a history of thoracic compression fractures and some tenderness through her ribs. So I was not able to do this motion with her as fully. But I wouldn't necessarily say this was an adapted 7 stages of Spencer, but I am testing some range of motion and I want to move fluids. I want to lubricate the joint, and I'm just nice and easy getting some range of motion. So he's not having pain, so I can run his arm through this and down. And I will do the same on the other side, but for this demonstration, I'm not going to do that because I think that you won't see the motion. Let me just try it. I'll see how much you can see. I think you're only going to see my back. Can you see that? So I have one hand in the axilla. I'm doing a little bit of pumping up into that region, moving lymph, moving ribs, moving clavicle. And I'm going to take the trajectory of this arm in a 30-degree angle, 45 and 90. I'm using my full body weight, just kind of leaning and leaning and leaning, a little stretch. A nice little rowing motion to get full rotation through the shoulder to their range of motion. And I'm going to switch positions and tuck his arm under mine. I can traction here. And as I hold and give a little traction, I'm also thinking about the opposite hip. Just a nice stretch all the way down through lats. And I'm going to cup my hand and walk down the ribs. Monitoring, I'm watching his face, I'm watching my patient's breath, and I'm probably talking about how things are going at home and, making conversation. So walking down the ribs, good motion through the ribs, right? Good. Oh, little stretch upward. Range of motion. Good. And down. This would be a great time to just transition to some rib raising. really gentle articulatory. My fingertips are spread. I'm going to start up at the top. One hand is under the traps. And I'm going to just move that clavicle forward and back. Motion testing, but also moving fluid simultaneously. Right. And I'm going to bring my hands under the upper ribs. There we go, making contact with the rib heads, and I'm sinking into my knees, moving his ribs, nice and easy. I'm going to move my hands down a little farther. Same thing, sinking and lifting those ribs. And excuse my back. So I've treated that side. I'll go to the other side with some rib raising. Get all that nice soft tissue with my hand underneath traps. I have the whole scapula, I have the shoulder in my hand, and I'm mobilizing rib 1, putting a little pressure on clavicle. You might call this a generalized osteopathic treatment. A lot of range of motion, fluid motion. Remember that there's 3 ways to move lymph. One is with the breath, laughing, crying, really moving, through muscular movement, voluntary motion, that's number 2, or manually moving it. So I am manually moving the ribs, I'm manually moving lymph. My intention is to continue to rock the rib heads and do some motion. I'm sinking into my knees. If I were in the hospital setting on the bed, I would have the bed a lot higher. And then I get to use my arms as levers and not put a lot of pressure on my wrists because I want to be able to do this for a long time. And then now for the lower ribs. Sinking, good. Yeah. And I'm just getting a sense of external motion. A good sense of ribs raising and falling through the breath. I'm going to move to the pelvis and sacrum. Just with my hands on the ASIS, I'm going to rock the pelvis. This also rocks the sacrum. It's almost like you're kind of emulating the motion of walking. When you have your hands in this position, you can add a little rotation to the innominate, a little sideways rocking. For the hip. Very gentle articulatory, so I've just got a good hold of the leg and I'm bringing the femur in relationship to the innominate. Just a little hung up there as we begin to externally rotate. So I'm going to be mindful of that motion. It's not painful, is it?
No.
Yeah? No? No. Okay. A little traction, a little rocking. I might add a little proprioceptive neural training where I'll say, I'm going to support my patient's entire leg, and I'm going to ask you to press your leg into my arm. And I'm going to give a little resistance. So keep pushing, 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 pushing. And now can you bring your leg up? And I'm doing a little resistance here. So go ahead and bend your knee towards your chest yet. And press towards me. Push, 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 push. And pull, 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 pull. And push, 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 push. And pull, 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 pull. So I'm resisting the motion, and I'm giving them a little bit of something to press against. And one more. Great. And relax. Good. Great. Popliteal fossa as well, just lifting, spreading. The hand that's more lateral has access to the fibular head, so I have a sense of how that's moving. I'm getting a little motion fibular head. All right. And of course, the plantar aspect of the feet, other diaphragms. So I might take my stool or a seat and plant myself right down here and articulate through all the metatarsals and phalanges, and encourage the arch of the foot to comply, walking along the arch, navicular, talus, a little rotation outward, moving the bones. I want to get everything moving. Yeah. Good. So then I would repeat it to the other side, which I don't think it makes sense for me to do this because you'll only be seeing my back. I also have to duck out to see how we're doing on timing. So 22 minutes. We're at 22. So I'll do it now. But take the entire leg, a little range of motion, rocking it, massaging the head of the femur in the hip socket. And this is his replaced hip, and it's got really great motion. And I might do a little, go ahead, we'll do that proprioceptive neural feedback, that training. I'm going to give a little bit of resistance as he extends his leg outward. Go ahead and push, 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 push. And now bring your knee towards you. So you flex, I'm resisting a little bit, but following the motion. Go ahead and push again. I'm resisting, but following. And the same way in. And one more time. Out, 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 out. Good, good, and relax. Good. Popliteal fossa. Making a little bit of space behind the knee. Also, my hands, lateral hand on the fibular head. Rocking that in its place just a little bit. And then I'm going to turn, and I'm going to take this foot, really emphasize the arches, moving plantar fascia, little rotation at the ankle. I want all these bones to move just a little bit more. Just a little bit more. Yep. Great. Back to the side. So the point of treating our older patients is to position them comfortably, optimize motion, treat the diaphragms to optimize all fluid motions, improve circulation, right? Improve digestion. How can you do that? By a little colonic lift. So I might start on the left side. I'm going to adapt this a little bit. And I am making contact. It's hard to feel the left side of the colon, but my fingertips are going to swoop under a little. I'm going to be mindful of his thoracic respiratory effort and suggest the fascia and colon a little more midline. Thinking about the omentum, thinking about the colon. I'm going to follow that along just a little bit. Good. Now my fingers are going to go under the ribs just a little. They're not pokey, but I'm using the sides of my fingers and just a little caudad motion, suggesting space for colon under the ribs. Can feel the lymph moving, feel momentum moving. I'm just following it. I come to the right side, ascending colon, and I'm going to make contact. I'm going to lean back a little bit, hold, and so pretty simple, gentle, emphasis on moving fluids and diaphragms. I want to share my screen with you for a moment because my patient asked, let's see, if I could give her exercises. So let's see. Oh yeah, here we go. Okay, just a reminder. Our goal is to return our patient to a degree of independence and daily activity and to prevent secondary disabilities, to restore function, to assist the respiratory mechanism, and stretching tight fascial sheaths through slow, gentle range of motion, mobilizing the fluids, aiding digestion and elimination, and hopefully relieving pain. Here is LM. Let's see if I can get you to this. Our next one down. Okay. Here she is again. That was my model patient. And sorry about that. Okay, here we go. Good, good, good. One more. Here she is. I said, hey, she's already working with physical therapy. So I taught her to circle all of her joints. So here she is. And I'm doing this with her. There we go. Let me stop. There will be. Okay. And let's go away from that. Okay. And stop my share. There we go. Thank you so much. And hope you enjoy the rest of the conference. Please feel free to contact me if you have any questions. My email is posted at the end of the PowerPoint from the first lecture. All right. Take care.